So in this lesson, we're going to specifically focus on what is occurring in those first few minutes after injury. But before we get too far into a discussion on the healing phases and the specific aspects occurring within each, it's important that we pause for a moment and pay attention to what we do and what we actually don't do. So it's important to remember always that we do not speed up healing. There really is nothing we can do, no treatment healing modifier that we can uh, employ that will speed up the body's natural healing rate. The best we can hope to do is introduce external energy, thermal, electrical, mechanical, light, any of those to try to optimize the environment for healing to occur. The human body is going to have to heal itself. There's no healing that we actually can do. With that, all we're going to really do then is apply these agents based on these four principles. The characteristic of the vascular and cellular response during that particular stage of healing, specifically what is going on. That's why we're focusing on these cellular and vascular responses, so we have a good understanding of what is going on. So we then can continue on and understand the specific physiological or neurological responses that the therapeutic agents can and do affect. And then we also have to always consider any potential detrimental effects. And those are our contraindications aspects. So we're just going to try to modify and understand what is occurring physiologically to create the best and most optimal healing environment. So we've continued to look at the injury process as a whole throughout this unit. But right now, I want to give a different interpretation of that. We've talked about the three healing phases. You've learned about primary injury versus secondary injury. But I want to think of this from the standpoint of almost a 5-phase approach, where we normally have the acute inflammatory phase that we think of. But that's really two different phases. It's going to be our first limiting blood loss phase. Then it is going to be our acute inflammatory phase. Then we start to get into tissue repair and proliferation, and then maturation. So we'll talk more about these as we go, but right now we're going to talk more about limiting blood loss specifically in there, and then get into that acute inflammatory response a little bit. So when we're talking about limiting blood loss and hemorrhaging and then that effect on swelling, we're talking about in those first few minutes, right? Seconds to minutes is all we're talking about here. Otherwise, much more than that, and you would actually get, severe internal bleeding that would be even more problematic. So when we're looking at this, we normally have platelets that are flowing through the capillaries. And normally within a normal capillary flow, the platelets flow more towards the middle, right, as well as the cells, and then the plasma are on the outside. After an injury, though, right, the plasma starts to escape. And so the platelets then migrate towards the edge and start to adhere and create what we call a platelet plug. And that occurs almost immediately that we get this platelet plug. But that platelet plug is relatively weak in its ability to maintain its structure and hold the blood in, right? We're trying to cover up these holes that have occurred when the tissue rips. The capillaries are there as well, and so they're going to rip or get crushed or whatever the injury is. And so we're trying to plug and stop the bleeding. But since that platelet plug is relatively weak, we then have to come through And through a conversion of prothrombin to thrombin to fibrinogen, not, that's particularly the most important thing to understand, but we get this immediate aspect here where, due to the chemicals that are being released in there, that enzyme factor X, we get a reinforcement of that platelet plug with fibrin. At that same time, these enzymes are releasing chemicals that are immediately going to vasoconstrict to try to decrease the amount of blood flow to that area, right? Epinephrine is one of the big ones there that immediately goes through. And that's why I specifically like to include this limiting blood loss, because a lot of this stuff that we talk about and we think about are due to this idea that we need to decrease swelling and try to prevent swelling from occur by decreasing blood flow following an injury to the capillaries. But within a few minutes, we have a restoration of normal blood flow to there. And so it's going to then get into this idea of the acute inflammatory stage, that we get more of the formation of swelling. Most of the swelling is not, in fact, bleeding, but is due to other things that are occurring in this acute inflammatory stage. So I specifically want to talk now about this acute inflammatory stage that's occurring right afterwards. You see all of this different overlap, different aspects. The specific time frame varies greatly based on the individual, the type of injury, all that sort of stuff. And so trying to understand it from a specific time frame is not as valuable as understanding what and interpreting what you are seeing. So as we go and talk about this, we're going to talk about swelling and edema a little bit. But at that same note, realize that the acute inflammatory response is healing. Inflammation is a necessary and vital part of healing. It is the body's healing process. We need the increase in blood flow in order to increase the healing agents that occur. We need these phagocytes and fibroblasts to go to the area to start the healing process. And so the main chemical, and we will see several of these, is going to be histamine. But there are several, and here are lists of these different mediators within the inflammatory process. Like we see, histamine from these mast cells that are some of the first ones there are the ones that are going to do vasodilation. But see, we have all of these different things that are going to be occurring. Both sides, you can see that. Neutrophil chemotactic factor, right, which attracts neutrophils to the area to start to phagocytize the necrotic tissue. Obviously, we have this tissue that is broken, right, and we need to get rid of that waste. And so all of these chemicals combine to allow for healing to occur. Without what we're discussing here, there is no healing. So when we try to think that we constantly need to decrease inflammation, it's important to realize that there is an appropriate level of inflammation, and understanding what that appropriate level of inflammation is probably more important than constantly assuming we need to decrease inflammation. And so we'll talk more about that throughout the discussions of healing process, but always remember that this is all set up to bring what we need to have in the area for healing to occur. When we get into the other steps of the healing process, without this initial acute inflammatory process that has all of these different cascades and all of these different chemicals bringing different cells and stuff to the area, we would not be able to move to the next stages and get healing. And so that brings us into this practical evidence box 1, 3. And we've discussed this in other classes, the idea of rice, price, police, all of these. The fact with this is there is no individual one process that is always applicable within these situations. And the fact that, rice, price, police continues to change is demonstration of that. So instead of learning an acronym, it's more important that we learn these physiological processes and then how we can utilize what the body is naturally doing, try to help it and optimize it opposed to trying to completely control it and counteract it. And so this idea comes from some of the discussions we've had earlier and some of the videos watched earlier, specifically on the amount of physical stress and understanding the role of physical stress in healing. And so we need an appropriate amount of physical stress to maintain this healing process. And specifically, we will see some of this within the ability to progress and optimize healing as well. So when we get to this acute end of this acute phase, what we're trying to have accomplished during this acute inflammatory process, we have now the promotion of inflammation. All of those different chemical mediators have created a situation where we have more inflammation, more blood flow, more capillary permeability, and this chemotaxis of neutrophils, specifically monocytes that become the macrophages. And then the main purpose of the acute inflammatory phase is this chemotaxis of neutrophils to get phagocytosis in the macrophages, which will then start the process of repair. And so we will get more into some of the specifics in this acute inflammatory phase when we get into the other phases of healing and the traditional 3 phases of healing that we will talk about. But keep in mind, at the end here, we have a promotion of inflammation. We have the conditions for removal of waste, right? Increased blood flow, increased capillary permeability, and phagocytosis. However, we also need to address this idea of swelling and edema and these consequences of injury. We need inflammation because we need the fluid and the cells that the fluid brings and the nutrients that the fluids bring. What we don't need is swelling and then specifically edema. Swelling is just that increase in the volume of fluid. Right, as it builds up. It's your body's natural way of bracing, protecting, and flooding the area with nutrients, cells, and fluid, all the things we need to heal. What we don't need then is edema, which is that excessive buildup of fluids. And specifically, think of edema as not too much fluid in the air, but not enough drainage of fluid. The edema actually disrupts and the lymphatic flow, which removes these solid waste and it gets plugged up with these solid wastes. So we need to keep fluid moving, not necessarily decrease the amount of fluid. So when we look at this and understand how this occurs, right, because we need to understand how this occurs so we can understand any areas of manipulation with that, we have to start with Starling's law. And this is the movement of fluid based on 2 different things that's occurring. Hydrostatic pressure, think of this as blood pressure or pressure, like just, pressure out of a hose. Think of that. And then you have colloid osmotic pressure. And osmosis, remember, think about osmosis back to your high school biology class. Osmosis is the movement of fluid across a membrane. And if you remember with that, if you have a membrane, that eliminates the ability for solutes to diffuse because they are stuck within one side of this diffusion. However, water can still move across that membrane. So in uh, osmosis and osmotic pressure, we have a pressure pushing fluid into the area of a high concentration of solutes. So this is how our body normally works. You have blood pressure, and think of your capillaries then as almost like a soaker hose, for the garden where you put, a soaker hose and has very small holes and the water just kind of oozes out. And if you turn up the pressure, more water oozes out. You turn up the pressure enough and it squirts, right? That's what is going on here. We have these little holes, the blood pressure goes and pushes fluid out. And at the capillary and arterial, we have a net filtration pressure or hydrostatic pressure of 10 millimeters of mercury out. And so we get a movement of mercury out. We have hydrostatic pressure of 25 millimeters of mercury. We have osmotic pressure of, or I think I said that backwards, capillary or hydrostatic pressure of 35 millimeters, osmotic pressure pulling in of 25 millimeters, and so we have a net out. We have fairly equal at the mid capillary, and then at the end, the blood pressure you can see has decreased greatly, but the osmotic pressure doesn't change because we don't have a change in the solute concentration, right? We're only moving fluid, but we still have blood cells, plasma proteins, all that within the capillaries that are pulling fluid back in. And so we get a movement in there. And you can see here, right, however, just based on this, we have over the course of a capillaries a +3 millimeters of mercury pressure movement out overall. And that's why we have the lymph system to collect that extra. So when we think about this and look at it, we need to understand what occurs after injury in hydrostatic pressure as well as osmotic pressure. And so one thing here you can see, right, hydrostatic pressure changes by the position of the limb. It also changes as blood pressure changes, but manipulating blood pressure is a lot harder than limb position. So after an injury, however, if you remember, we increase the capillary permeability. And as we increase the capillary permeability, that's really important for this margination of white blood cells or leukocytes. Margination is just the movement of these out into the area so that they can do the things that they need to do. But as cells and plasma proteins and all that move out of the capillaries, we get an increase in the osmotic pressure within the interstitium and the interstitial fluid. And because of that, we get a change in those overall pressures and we have less pulling of fluid back into the venules and it stays out in the interstitium. And that's what creates the swelling, is this change in the osmotic pressure from the venules pulling it in to now a more neutral with plasma proteins cells being both in the venules and in the interstitium. And so the only way at this point then, once we have this situation where the plasma proteins are eliminated and the cells are going through it, and we need this to occur, right? We need the cells to get out of the bloodstream and get into the interstitium where they can fix the injury that occurred. We need that to occur, so we don't really want to eliminate that. However, the only way then to eliminate this is through the lymph system. And the lymph system is passive. Right? It's passive, and so it's reliant on these one-way valves. And so we can try to minimize and control some swelling, right? Elevation reduces the hydrostatic pressure with that external pressure, minimizes osmotic pressure, as well as increases slightly the hydrostatic pressure of the interstitium, right? Because you're squeezing that area as well. Ice, we'll talk a lot about ice in different areas, but there's not a lot of great research. There's some talk about electrical stimulation altering capillary membrane permeability, but then we have to go back to the idea, is that in fact something we should be doing? But our real thing then is we need to get rid of swelling, and it's removed by the lymph system, not the circulatory system, and this is best accomplished through muscle contraction. As we contract the muscles, we squeeze the lymphatic venules. Right? This shows veins, but it's the same sort of function within the lymphatic system. You squeeze it, it goes up. When it relaxes, it cannot go back because of these one-way valves. And so when we look at swelling and specifically edema, we need to think then about how we can increase lymphatic flow. That's how you eliminate edema. And the best way to do that is through muscle contraction, not aggravating the injury, causing too much. Because if you continue to aggravate the injury, you can get into a situation which is like chronic inflammation, where the symptoms of the acute inflammatory process persist longer than needed. There are different causes in there that occur, right? Most of the time we're talking about this constant irritation, where we get a primary trauma that causes cell death and inflammation. We get that hemorrhaging and edema with that. But if that is not resolved and we don't get the blood clotting, the revascularization, and return to normal function, we can get caught in this loop of pain, spasm, atrophy, blood flow congestion, potentially hypoxia and cell death, enzymatic injuries, all this sort of stuff. And you can see how this just continues to go on. And that's why chronic inflammation is a strong predictor of future disability, because we continue to get inflammation, we continue to get death, we continue to get the possibility of even some of this phagocytosis to occur, but we never get to the point where we get healing, and we just get an overall breakdown of the tissue. And so once we get into this chronic inflammation, now this is a cycle that we need to break. So chronic inflammation is not healing, right? Acute inflammation is and leads to healing. So we don't need to always eliminate inflammation. We need to make sure inflammation moves out of this situation, which leads into edema and then chronic edema and hypoxia because of the blood flow congestion and specifically lymph flow congestion. We need it to move then into clotting, revascularization by eliminating the cause of the trauma, right? And at that same note, then eliminating the edema so that way we can get healing to occur. Another area that is talked a lot about is that secondary cell death and how much of that really is occurring. And it's, was originally proposed by Knight due to this lack of oxygen, and that's why it was suggested to immediately apply ice to decrease the cell metabolism. There's some problems with that, primarily from the standpoint that the lack of oxygen isn't as common as some of these other sorts of things, calcium, oxidations, mitochondria things. It's probably secondary cell death, however much occurs, which it's almost impossible to determine what is caused by primary cell death and what's caused by secondary cell death. But it's much more complicated and probably more of a result of a crisis of energy than it is about a true hypoxia and a lack of an ability to produce energy because of lack of oxygen. But at that same note, I put this picture over here because all of the research associated with secondary cell death is all been done in rats with crush injuries, which are much more substantial than our normal musculoskeletal injuries. And so it's possible, obviously you can't do human injuries because we cannot go in there and cause injuries, and we need to follow them immediately. So we need to know when the injury is occurring. But a crush injury is obviously much more severe than normal injuries. And so that's the end of our discussion of this first phase that's really occurring immediately before this, right? This is our normal, picture includes our normal acute inflammatory our healing phase, talking about the acute inflammatory phase, moving into the tissue repair and regeneration phase, and then the maturation and remodeling phase. So we will talk more about these later as we get into those specific topics. As always, if you have any questions, let me know. Otherwise, have a great day.